Okay, chapter 30, skeletal muscle, bone, and joint disorder drugs. So drugs used for skeletal muscle issues, bone issues, joint issues in acute musculoskeletal injury. So that's like it just happened. It's got a very identifiable cause. It's less than 3 months of issue, right? A skeletal muscle relaxant may be prescribed to help with healing. Relax the muscle, give it some time to heal, helps with the pain, right? So for acute injuries, skeletal muscle relaxant is a great option. But with chronic diseases of our muscles or our joints, etc., we need a medication we need a medication that can be given to maintain our function, right? To keep us going. And a skeletal muscle relaxant may not be the best option for long-term use. Okay. So what can we give for people with chronic issues if we're not going to give skeletal muscle relaxants? Well, we can give DMARDs, disease modifying agents. We can give bone reabsorption inhibitors if it's something like osteoporosis. And we can give uric acid inhibitors for diseases or disorders like gout, right? So let's talk about some of these issues that can result from dysfunction of our musculoskeletal system. There's synovitis, which is a joint inflammation. It's actually an inflammation of the synovial membrane that causes pain, swelling, and really happens when we have like rheumatic fever, rheumatoid arthritis, or gout. We might see some synovitis. Arthritis in general is joint inflammation that causes stiffness or pain. Osteoarthritis, sometimes called or turns into a worsening condition called degenerative joint disease, DJD, is degradation of the joint cartilage that causes changes that happen in that synovial membrane, and then hypertrophy of the bone at the margins. So the bone is growing. Maybe you've got some bone spur development. You've got synovial inflammation and changes in the membrane, and you've got joint cartilage breakdown. Rheumatoid arthritis is a chronic systemic disease that causes inflammatory changes throughout the connective tissue in the body, and it can affect joints, organs. It can result in articular cartilage destruction. It can cause joint structure issues with stability, etc. And then it can also cause issues in mobility. We start to see rheumatoid arthritis bear its ugly head between the ages of 20 and 40. Osteoarthritis is usually a little bit later. Rheumatoid arthritis is autoimmune, and it affects many joints. It is symmetrical. So if you have a bad hips, it's bad left and right hips. If you have bad wrists, it's bad left and right wrist. Versus osteoarthritis is really from use, right? Use or abuse. So you have one bad hip, or you write with your right hand a lot. So now you have arthritis in your right hand and wrist. Does that make sense? Whereas rheumatoid arthritis is really an autoimmune, autoinflammatory condition where your body is attacking itself. Gout. Gout is a type of arthritis. It is an arthritis caused by uric acid accumulation in the blood that ends up in the joints. Okay. Urate crystals get deposited inside the joints, and that's very painful. It causes redness and swelling and inflammation, and even like nodule formation. Gout comes with exacerbations called gout attacks, and those attacks are extremely painful. And then there's osteoporosis. This is loss of bone density. We see this a lot in postmenopausal women. The bones become very porous, very brittle, and break easily. Hypercalcemia would be almost the opposite, right? We have too much calcium, specifically seen in advanced stage cancers, right? So of malignancy means of cancers. It occurs in 10 to 50% of tumors. The client may also be lethargic, anorexic, but they may have nausea or vomiting. They may be extremely thirsty or want to drink a lot, called polydipsia. They might be constipated, and they might become dehydrated. If untreated, hypercalcemia of malignancy is going to cause cognitive issues, confusion, obtundation, and coma. And then there's Paget disease. This is osteitis deformans. It's a chronic bone disorder. It's characterized by abnormal bone remodeling. The disease disrupts growth of new bone tissue. It causes the bone to get really thick and soft, which weakens the bone and increases the risk of fracture of the bone or the bone collapsing, even with slight trauma. So these people end up breaking pretty easily because their bones are mushy. Okay, their bones no longer are growing in. There's no replacement of good bone with new bone tissue, new strong bone tissue. So oftentimes it is genetic, or over time we have issues with breaking and misshaping a bone. So what kind of drugs can we use? We talked about them up here. We said we can use DMARDs, bone reabsorption inhibitors, and uric acid inhibitors for chronic problems. And we can use skeletal muscle relaxants for acute problems. So let's start with chronic. Let's talk about DMARDs. DMARDs are disease-modifying anti-rheumatic drugs. Really common one that we use for many different autoimmune conditions is hydroxychloroquine, also known as Plaquenil. We could also use methotrexate, sulfasalazine, and leflunomide. So those are just your general DMARDs. Then we have DMARDs, or disease-modifying drugs, that are biologics. So they are TNF inhibitors. TNF is tumor necrosis factor, and TNF inhibitors work by inhibiting TNF alpha. It's a protein involved in the immune system. It really produces a lot of inflammation. So if we can change the way the immune system responds to stimulus, then we can decrease the inflammation that these clients are experiencing. And so the biologic DMARDs are abatacept, adalimumab, which you may have heard of, Humira, etanercept or Enbrel, golimumab or Simponi, and infliximab or Remicade. Okay, those are your biologic DMARDs. So general DMARDs, hydroxychloroquine, methotrexate, sulfasalazine, leflunomide, and then biologic DMARDs are the others. Action. What do these do? In general, DMARDs suppress the immune response. So they decrease that autoimmune activity that's causing the inflammation. We use these a lot in conditions that have extreme inflammation and pain that's caused by an autoimmune situation. Rheumatoid arthritis, right? Rheumatoid arthritis is systemic. It's autoimmune mediated. So when NSAIDs and steroids no longer work for pain and inflammation, we have to move on to something else for people who have rheumatoid arthritis. RA can be extremely painful. So we may get them on a DMARD. Additionally, we can use DMARDs for Crohn's disease, which is also autoimmune, right? Fibromyalgia. And then methotrexates are also used in cancer therapies. Adverse effects of DMARDs. DMARDs can cause nausea. They can cause inflammation, irritation, dryness of the mouth, stomatitis. They can cause hair loss, alopecia, right? Sulfasalazine can cause changes in the eyeballs and the ability to see, ocular changes, right? It also can cause GI signs and symptoms, maybe some mild pancytopenia. Injectable drugs can cause some skin irritation, specifically at the injection site. And then biologics can cause flu-like symptoms. So maybe some like just fatigue, lethargy, malaise, maybe a little bit of nausea, right? And then also a risk of infection because they're decreasing your immune response. Therefore, you're at higher risk for contracting an infection like tuberculosis. Who shouldn't get a DMARD? Well, if you're allergic, you shouldn't get a DMARD, right? And then specifically with like the individual drugs, and I have these kind of color coordinated, people with liver disease, who abuse alcohol, who have low blood cell counts, who have kidney issues or have a folate deficiency shouldn't take methotrexate. Clients who have congestive heart failure or a neurologic demyelinating disease like multiple sclerosis should not take etanercept, adalimumab, or infliximab. So those biologic DMARDs. And then clients who are taking etanercept, Humira, or Remicade should not take anakinra. Okay. There is just a not great reaction between the two. Okay, precautions. If your client is obese, they have diabetes, they have hepatitis, they're pregnant, or they have a liver disease, we need to be very careful giving them these medications, specifically DMARDs with liver issues, right? Not good to mix the two. And then if your client has a sulfa allergy, right? They probably shouldn't take sulfasalazine. That makes sense, right? And then we don't want to mix sulfa antibiotics with these medications. It increases specifically the methotrexates because of increased risk of toxicity of the methotrexate. And then aspirin and NSAIDs can also increase the risk of methotrexate toxicity. Bone reabsorption inhibitors, also called bisphosphonates. Who are these used for? These are used for people with osteoporosis, Paget's disease, or hypercalcemia, which is too high calcium in the blood, therefore not the bone. Medications that are the bisphosphonate examples include alendronate, which is Fosamax, probably the most common one. Atidronate, Didronel, abandronate, Boniva, pimemidrinate, risedronate, zoledronic acid, reclassed. Okay. These medications are going to help increase bone density. They act on the bone. They inhibit bone resorption. So that's where your body or osteoclasts break down your bone, and then your body resorbs the bone itself, the calcium from the bone, right? Causing increased calcium in the blood, decreased calcium in the bones, so decreasing the strength of the bones themselves. And so these medications inhibit bone reabsorption, and that causes increased bone mineral density. It reverses progression of osteoporosis, and it improves the strength of the bone. So like we said, used for osteoporosis, hypercalcemia, and Paget's. Adverse reactions. Bisphosphonates cause serious dyspepsia, regurgitation, like GER, reflux, nausea, etc. So you want these clients to sit up for at least 30 minutes after you give this medication, because it's going to cause really bad esophagitis or inflammation of the esophagus, irritation, right? Additionally, these can cause diarrhea. They can cause increased or recurrent bone pain. They can cause headache. They can cause dysphagia or abdominal pain. Specifically, denosumab can cause hypokalemia, potential increased risk for femoral fracture, osteonecrosis of the jaw, and potential skin reactions. Contraindications. If the client is allergic to the bone resorption inhibitor or the bisphosphonate, they shouldn't take it. Clients that have low calcium in their blood should not take alendronate or risedronate. Alendronate should also not be taken during pregnancy. Bisphosphonates in general are contraindicated in clients that have delayed esophageal emptying. So they're really like maybe they have achalasia, or they have dysphagia, or they have esophageal sphincter incompetency, right? Or if they have kidney issues, or if they're on hormone replacements. We don't want them to take a bisphosphonate. We want to be really careful in clients that are pregnant or they have cancer, pregnant and they have cancer, giving these medications. So if they have hypercalcemia due to cancer, we have to weigh out the risk to the pregnancy versus the benefit of treating the hypercalcemia. Interactions. Calcium supplements or antacids with magnesium or aluminum can actually decrease the effectiveness of bisphosphonates. So we don't want to take them with extra calcium, right? Because we don't want to increase the calcium level of the blood. We want to increase the calcium level of the bone. Aspirin actually increases the risk of bleeding when given with bisphosphonates, and then theophylline can increase the risk of theophylline toxicity when given with bisphosphonates. So bisphosphonates, bone reabsorption inhibitors, good for people with osteoporosis, hypercalcemia, or Paget's. It's going to increase the calcium level in the bones, decrease the calcium level in the blood, and lots of good examples of those. So I wish we could talk about the third chronic medication before we move on to the acute, but it's your PowerPoints take a quick break and talk about the acute medication class of skeletal muscle relaxants. So you've got an injury, maybe you pulled your shoulder throwing pitches at the baseball game, right? It's an acute injury. It's going to go away hopefully within 3 months or so. Identifiable cause, right? Somatic pain. We need to treat it with a relaxant. Good examples of relaxants: baclofen, carisoprodol, cyclobenzaprine, dantrolene, diazepam. Oh, look at that. Metaxalone, methocarbamol, orphanadrine, or tizanidine. Okay, so you've heard of Flexeril before, right? Okay, these are skeletal muscle relaxants, though we don't know exactly how they work because many of them don't work actually on the muscles themselves. We know that some of them help to provide sedation, and sedation itself is going to relax the muscles. The only medication that really does affect muscle directly is cyclobenzaprine. It decreases muscular tone to help reduce muscular spasm. We use these for acute painful musculoskeletal conditions like muscle strains or back pain. Adverse effects can include drowsiness, sedation, sleepiness, lethargy, constipation, diarrhea, bradycardia or tachycardia, and potentially even rash. If your client's allergic, they should not take a muscle relaxant. And then we don't give baclofen to anyone with a rheumatism spasms that are experiencing spasms of rheumatism. Carisoprodol, we don't give to anyone who has an allergy to meprobamate. Cyclobenzaprine, we don't want to give to anybody who's had a recent heart attack or has an issue with cardiac conduction, like a some type of block, or has hyperthyroidism. Additionally, if your client has taken an MAOI in the last 14 days, they should not take cyclobenzaprine. We don't want to give oral dantrolene to anybody who is lactating or has active hepatic disease like hepatitis, or is experiencing muscle spasm related to rheumatic disorders as well. So spasms from rheumatism. Precautions. If your client has a history of stroke, CVA, cerebrovascular accident, if they have a history of cerebral palsy, if they have Parkinsonism, if they have seizures, if they're pregnant or they're lactating, we want to be careful giving them a skeletal muscle relaxant. Additionally, cariprazole, we want to be careful with clients that have severe liver or kidney disease, clients who are pregnant or lactating. Cyclobenzaprine, we want to be careful with cardiovascular diseases, pregnancy and lactation, and the dantrolene is a big pregnancy risk as well. So risk versus benefit, the doctor's got to decide what to do. The last class of chronic. So we talked about bone reabsorption inhibitors, bisphosphonates. We talked about DMARDs, disease modifying antirheumatic inhibitors, right? Or excuse me, drugs, right? That work to decrease the autoimmune responses of things like rheumatoid arthritis. Let's talk about the last chronic medication, uric acid inhibitors. And this is used for gout, right? So uric acid arthritis is gout. That's what we use this for. These medications treat, manage, or prevent gout attacks. Examples: allopurinol, colchicine, febuxostat, pegloticase, and probenecid. Very common medications to see on older people's med charts, right? Med list, because they are clients are more likely to experience gout and develop gout as they get older, especially older men. Allopurinol works, they all work a little bit differently. So I have them individually categorized by their action. Allopurinol works to decrease the production of uric acid. Febuxostat works to decrease uric acid levels in the blood. So allopurinol decreases the uric acid production. Febuxostat decreases how much is circulating. Colchicine, we don't know exactly how it works, but we know it actually decreases the inflammation in the joints themselves. Pegloticase is an IV infusion that decreases the amount of uric acid circulating. Probenecid decreases the amount of uric acid in the body as well, but it also can be given with colchicine to treat the inflammation. Okay. Adverse effects of gout medications or uric acid inhibitors: nausea, vomiting, diarrhea, abdominal pain, headache, urinary frequency. With allopurinol, big thing here, skin rash, Stevens-Johnson syndrome. We see that with allopurinol. With colchicine, we see severe nausea, vomiting on occasion, bone marrow depression due to the effects of the medication. It is a second line drug. It's not going to be your first. So you start with allopurinol. If that medication doesn't work, you probably give probenecid. If probenecid doesn't work, you may end up adding colchicine to see if that works, or trying a different uric acid inhibitor. Okay. Contraindications: if you're allergic to the medication, you shouldn't have it. That should go without saying at this point, right? With colchicine, we don't want to give to anybody who has severe GI issues or a renal, hepatic, or cardiac disorder. Additionally, because it causes bone marrow suppression, if your client has a blood dyscrasia or a difficulty bleeding, we don't want to give them the medication. Probenecid, if they have a blood dyscrasia, difficulty bleeding, we don't want to give them the medication. If they have developed uric acid kidney stones from the gout, we don't want them to have it. And if they're less than 2 years old, it is contraindicated, probenecid. And then febuxostat, patients taking azathioprine, mercaptopurine, or theophylline should not take febuxostat. Precautions: we want to weigh risk versus benefit in clients with renal impairment or clients who are pregnant. Specific medications: with allopurinol, if they have a liver impairment, we want to be careful administering allopurinol. If they have a sulfa allergy or peptic ulcer disease, we want to be careful giving probenecid. And if they are old, they're more prone to the colchicine adverse effects. So we don't want to give colchicine to the elderly unless the doctor has really thought it over and thinks it's the best option for the client. Interactions: so allopurinol and febuxostat interact with ampicillin, theophylline, aluminum, antacids, and then probenecid interacts with penicillin, cephalosporins, acyclovir, rifampin, sulfonamides, barbiturates, benzos, NSAIDs, and salicylates. So tons and tons of interactions. Being aware of those interactions is going to be really important when you're looking at their med history, right? So here over here on the side, you can see ampicillin causes increased risk of rash, theophylline, increased risk of theophylline toxicity, antacids decrease the effectiveness of allopurinol. Your antituberculars and antibiotics can increase the serum level of the anti-infective when given with like probenecid, for example. Barbiturates and benzos given with probenecid can cause increased serum level of the sedative. So the benzos work or the barbiturates work better. So just be aware of that. And then NSAIDs increase the serum level of NSAIDs, and salicylates decrease the effectiveness of probenecid. There are a couple notable herbals for this class that work really, really good for the musculoskeletal system and associated disorders. Glucosamine and chondroitin are really great for arthritis, and both are naturally derived. They're herbal medication. You can get them over the counter at the pharmacy in the herbal department. They're going to be really good for decreasing inflammation related to arthritis. Okay, nursing process, assessment, get a good patient history of the injury, history of the disease, history of treatments that we've used, treatments that have worked, treatments that have not worked, baseline ADL ability. What can you do at home by yourself? What are you having troubles doing? You also need to look at labs, specifically your renal and hepatic labs, your calcium levels, if you're going to be giving a bisphosphonate, your magnesium levels, etc. If your client has had imaging done, like a DEXA scan to test their bone density, you need to be looking at that. Examine their arthritic joints. Look at how they look. Are they red? Are they swollen? Do they have nodules that have formed? Examine those joints and document the appearance. Document if they're deformed, if they're able to move them, etc. It's going to be especially important for gout patients because you need to be looking at those joints every 1 to 2 hours after administration of medication to see if it's improving. We should have pretty rapid improvement after giving a uric acid inhibitor to a client with gout. And then you need to be reassessing people with gout's pain every 2 to 4 hours and watching for those adverse effects to occur. You need to be doing a pain assessment on all clients with musculoskeletal injury or disease disorder. We also want to get baseline vitals, baseline weight. If your client is on bisphosphonates, we definitely need to get that serum calcium level before they start treatment, during treatment, and then after treatment to make sure we haven't caused any severe calcium imbalance. And then because so many of these medications are not safe during pregnancy, you need to assess for pregnancy before you begin treatment. Your RN might assign a nursing diagnosis of readiness for enhanced fluid balance because we need the client to take in more water to keep kidney stones from forming from that uric acid. The RN might assign impaired comfort, gastric distress, because we know that a lot of these medications irritate the gastric lining. Risk for injury related to maybe a medication-induced drowsiness, and risk for imbalance or falls from that, right? And then risk for allergy response related to the response of the substance trigger. So a drug allergy, right? Because a lot of these do have potential for allergy. Planning, what are our goals? Well, our goals are very similar to the goals that we always have, right? That we respond to the therapy. So that's going to depend on the medication. If it's a client that has an acute musculoskeletal injury and they're getting a skeletal muscle relaxant, we want to see that their muscles relax and that pain is decreased, right? If the client has low bone density due to osteoporosis and we give a bisphosphonate, we want to see improved bone density, decreased incidence of fracture, osteoblast activity, like those kind of things. So depending on what you're giving the medication for, we want to see that optimal therapeutic response. We want our client to hopefully avoid adverse effects, but if we can avoid them, then we manage them, right? And then obviously understanding compliance is super important. So interventions or implementations, what are we going to do? We should carefully monitor the skin and the mucous membranes for signs and symptoms of Stevens-Johnson syndrome, especially with like allopurinol, right? Looking for rashes, looking for lesions, sores, blisters, etc. We want to protect our client that is on a biologic DMARD from sources of infection, right? So we don't really do a whole lot of reverse isolation anymore, but we definitely want to make sure that people who are sick aren't around the client, that they're wearing a mask if they can wear a mask, that they are in their own room, those kind of things. Screen patients taking biologics for existing tuberculosis because there is that increased risk of infection, and we don't want to double down on their immune suppression, right? When they're already infected or they have a high chance of infection. Teach your patient to report any sign or symptom of infection to the doctor, even like cold symptoms or a really small sore. They need to tell the doctor. It's very serious because we're decreasing the immune system when we give a biologic. So they might not be able to fight it off, even if it's something as casual or no big deal as the common cold, right? You think about like NICU babies with no immune system. They don't do well when they're exposed to even mild infectious agents. So we definitely want our client to report any type of infection. We also want to pre-medicate our patients that are getting an IV pegloticase infusion with antihistamines and corticosteroids, because we know anaphylaxis or allergy is a common response to this medication. So we pre-medicate them with like a Benadryl or a steroid like a prednisone or a solomedrol or something like that to just decrease, or methylprednisolone, right, to decrease their reaction. We might not go into like a true anaphylaxis, and they may be able to get to the benefit of the infusion without the adverse reaction. Teach your client that improvement may take weeks to months, so don't get discouraged just because it's not happening right now. Immediately report any vision changes to the doctor. Encourage your client that has gout to drink lots of water and decrease their intake of alcohol, organ meats. We definitely want them to have lots of water. 3,000 milliliters of water is recommended. Bisphosphonates should be taken in the morning with 6 to 8 ounces of water, and the patient should remain upright 30 minutes after taking to avoid any GI issues. We also want to give DMARDs, uric acid inhibitors, or skeletal muscle relaxants to our client with meals so that they don't have GI symptoms, okay? Reposition your dependent patient every 2 hours to provide skincare to them so that they don't have breakdown. Teach your client not to drink alcohol and skeletal muscle relaxants, or drink alcohol with skeletal muscle relaxants, because they're going to have decreased central nervous system, right? Muscle relaxants are for acute injury only. Do not take more than 2 to 3 weeks. Acute injuries. Muscle relaxants are for acute injuries. And then use 2 forms of contraception while on the methotrexates, because we do not want you to get pregnant due to the serious effects on the fetus. Okay. Evaluation. Did the drug achieve what we wanted it to achieve? If so, we've accomplished our goal, right? Adverse reactions were mitigated or managed. The patient was able to verbalize the importance of compliance. They complied, they understood. Okay, couple questions. A variety of drugs are used to treat musculoskeletal injuries and disorders. True or false? Well, that's true. We just learned about 4, right? And that's just a few of them. So we talked about DMARDs, bone reabsorption inhibitors, uric acid inhibitors, and then the acute one, skeletal muscle relaxants. How about this one? Patients using DMARDs have specific drug routines to prevent gastroesophageal irritation. Well, that's false. That's not for DMARDs. That's for bisphosphonates. Remember, people on bisphosphonates or bone reabsorption inhibitors need to sit up for 30 minutes after administration of the medication to prevent irritation of the esophagus. Okay. And then with people who have like uric acid inhibitors, we want to watch for rash, and people who are on DMARD should be looked at for infection, right? And people who are on skeletal muscle relaxants, we worry about CNS depression. So different things to worry about with each drug, but bisphosphonates is the one that we're talking about, gastroesophageal irritation. Okay, that is it, guys. I hope those were helpful.